This lady has got a concealed accessory pathway, which means that she has an extra bit of wiring inside the heart connecting one of the reservoir to one of the pumping chambers, which conducts only in a retrograde direction. So you never see that on the surface electrocardiogram.
I'll just touch up to my little equipment.
We're all very used to taking ECG recordings from the surface of the body, and we're relatively used to ECG leads being placed in unusual sites for special purposes, like in the esophagus to study the right atrium. Perhaps one of the most unusual sites to place a lead, but when you think about it, perhaps the most logical site is the endocardium, the very inside of the heart itself. Taking readings from the inside of the heart isn't something we're ever likely to do ourselves, but it's important that we know about it, because it's becoming more common. Patients are likely to ask about it, and in some cases, it can save a lifetime on drugs.
Update. There's something in there, too. Onset, there.
Endocardial recordings can localize abnormalities precisely. The leads can be used to pace the heart, and abnormally conducting tissue can be ablated through the leads using radio frequencies.
Okay, we deliver some energy here. We have 146 milliseconds. 3, 2, 1, go.
20 watts, 120 ohms, 110 ohms.
Yeah, I think it has
20.
gone there, actually.
We've come here to St George's Hospital in Tooting, to one of only a handful of centres in the UK who are using this technique. Our guide, and the man who's going to tell us all about it, is Dr. David Ward, consultant cardiologist.
The general technique is called cardiac electrophysiology. It was first introduced into clinical practice in the late 60s, mainly for diagnostic reasons, investigating bradycardias. It rapidly became adopted in the States for investigation of tachycardias. In this country, its development has been very, very slow indeed. And I would say 10 years ago, there were only 3 or 4 centres in the country practicing cardiac electrophysiology.
What can it be used for?
The main application is for radiofrequency ablation, I would say. There are also other uses for diagnosing tachycardias of unknown origin, for investigating symptoms that may be due to tachycardias, such as unexplained fainting.
So the first thing is to get these catheters up into the surface of the heart, the endocardium. Can you just show us what the catheter's like?
This is one of the types of catheter that is used during electrophysiology. This particular catheter is a steerable catheter and can also be used for ablation. It has 4 electrodes on the end. The electrograms can be recorded from any combination of these electrodes. The catheter, by virtue of its steerability, can be placed in almost any part of the heart, so it's very, very useful for ablation. And this, in fact, has been one of the great innovations of catheter design over the last 5 years.
Could you just take us through the procedure itself?
The procedure is very straightforward. A diagnostic electrophysiology study involves the insertion of 2 or 3 electrodes into the heart, depending on the nature of the study. The electrodes are introduced through the femoral vein under local anaesthetic, and sometimes it's necessary to introduce an electrode through the subclavian vein to position in the coronary sinus to record electrograms from around the back of the heart. Interestingly, with the advent of ablation techniques, the electrophysiology study has become simpler. Now in this unit we only use 3 electrodes, whereas 4 or 5 have been used in the past. They're all inserted from the leg, and they can be moved around in the heart.
So we're measuring the interval between the stimulus and the onset of the atrial electrogram. And we're trying to find the shortest one.
The catheters can be used to record local electrocardiograms, providing simple activation patterns.
Pace a bit faster.
Or to pace the heart. Differential pacing can be used to test the heart's performance during conditions like tachycardias or premature stimulation. If a tachycardia is present, then the heart's response to drugs given intravenously can be studied directly. Slowing or termination of the tachycardia may predict a favourable response to further oral treatment. But one of the most exciting recent developments in the control of tachycardias has been the development of a technique called radiofrequency ablation, which actually destroys the abnormal excitation site and offers the possibility of a cure without continued drug treatment. And we'll hear all about that after the break.
Ready then?
Ready.
3, 2, 1, go.
20 watts, hence 120 ohms.
David, let's turn our attention now to the technique we've really come here to see, and that's radiofrequency ablation. Can you tell us what's involved?
Radiofrequency ablation is an extension of diagnostic electrophysiology. The key, really, to this technique is the insertion of the steerable electrode into the heart to locate the substrate. In this particular example, say we're trying to ablate a right-sided pathway which is somewhere on the tricuspid annulus. So the electrode is introduced up the inferior vena cava. The annulus is mapped using the distal pair of electrodes, and when we finally locate the spot where the pathway is by electrograms, we attach the electrode to a generator which delivers heat energy, and hopefully the pathway is destroyed.
What sort of arrhythmias can you use this to destroy?
Initially, the technique of ablation was applied only to the AV node, and in the old days it was high energy with the idea of destroying the AV node completely. With the advent of this technique, it's now possible to modify structures and to selectively burn them. So the two commonest arrhythmias to which this technique is applied are nodal tachycardias, atrioventricular nodal reentrant tachycardias, and the other one, arrhythmias complicating the so-called Wolff-Parkinson-White syndrome due to an accessory pathway. But it is also rapidly expanding to other areas such as atrial ectopic tachycardias, ventricular tachycardias, both on the right and left side. So there's a great deal of further development, I think, in radiofrequency ablation.
What would have been available for these patients before radiofrequency became available?
About 10 years ago, the only treatment for these people were continuing drug therapy, which of course carried the risk of side effects and intolerance and so on, implantation of a pacemaker to detect and terminate the arrhythmia, and finally surgery, which was of course reserved only for patients who were very, very symptomatic or at high risk. It was open heart surgery. It was about 90% successful, as opposed to radiofrequency ablation, which is about 95 to 99% successful.
So what sort of patient, what numbers of patients are you seeing?
Since the advent of radiofrequency, I would say our referral rate for curative therapy has quadrupled. Because, of course, it is one of the few things in cardiology, or indeed in medicine, which is truly curative, as far as we know. There are no long-term sequelae, and the risk is really minimal.
So from your point of view, it's a very big advance.
It's an enormous advance, equivalent to angioplasty, I think, in interventional cardiology.
David, what sort of patients still need to be treated by drugs?
Unfortunately, there are a group of patients who still require drug treatment. They are the patients with ventricular arrhythmias. Of course, most of these are patients who've had myocardial infarction, and as yet ablative techniques are not good enough easily to locate and destroy this type of arrhythmia. For these patients, they require drugs and often implantation of a defibrillator to terminate the arrhythmia. For the junctional tachycardias, such as I've mentioned, AV nodal reentry and Wolff-Parkinson-White type arrhythmias, there's no question that drug therapy is now second choice by far, and ablation is the treatment of choice.
So if you were to look into your crystal ball and look into the future, what do you think is going to be the future for radiofrequency ablation?
There's going to be an expansion into the area of ventricular arrhythmias. Mapping techniques are getting better. Ablation techniques with new electrodes coming along with bigger tips will be able to provide or cause damage over a larger area, and therefore make it easier for those more diffuse substrates to be modified or ablated. That's a very big area. The whole question of control of atrial fibrillation is now under scrutiny by electrophysiologists. It may be possible to apply energy to the AV node and modify it in such a way as that it is incapable of conducting rapidly. Whereas now we are either giving digoxin or some other AV nodal blocker, or we're going the whole hog and ablating the AV node and implanting a pacemaker. It may be possible to do selective modification. I think tachycardias of almost all varieties will be amenable to this technique within the next few years.
So some very big advances.
I think so.
Radiofrequency ablation, therefore, has a definite place in the management of arrhythmias. Its lower cost compared with surgery and the fact that patients do not have to take drugs long term gives it considerable advantages, particularly for our younger patients. A pity, therefore, that there are so few departments like this in the UK.
So we're pacing the ventricles now just to check that there is no VA conduction through the pathway, and as it happens there is also no conduction through the node as well. So we know that the procedure has been